Since I am pulling double duty today, I will go ahead and introduce myself as the third speaker. Again, my name is Dr. Katie Hendley. I am a movement disorder specialist and neurologist in Lubbock, Texas. I did my training, residency, and movement disorders fellowship at UT Houston, and then moved back home where I've been taking care of Parkinson's disease patients in Lubbock, Texas. So the goal of the talk, obviously defined in the title, was to take current guidelines and evidence-based medicine and then apply it to the general neurology clinic and hopefully give some takeaways and throw in a few clinical pearls into how you can apply that every day in your clinic. So we'll look at the diagnostic criteria because that's helpful. Initial treatment guidelines, which the AAN has produced some new initial treatment guidelines. Adjunctive and surgical treatment. We'll look at non-motor symptoms and then review the non-pharmacological treatment for Parkinson's disease. So in 2016, over 6 million people in the world had Parkinson's disease. It's interesting that this is 2.5 times higher than what we saw in 1990. Not sure exactly why. We're probably diagnosing it better, recognizing it better. The population is aging, they're living longer, and possible exposures to environmental toxins. But what this means is that likely anyone in neurology is seeing these patients in their clinic. Their access can be limited to movement disorder specialists, and so the likelihood of everyone sharing this patient load is very real. We do know that age is the greatest risk factor, and males have a higher risk. Most cases are idiopathic. Just one slide on neuropathology, I promise, not too much, but it is important to at least understand the basis. So when you are looking at a patient, you're educating them, and they say, "Doctor, why do I have Parkinson's disease?" Or is it because, I was an exterminator for a living, or I was in Vietnam? Maybe, but all of those questions are going to come. And so it's helpful to at least have some basis for that explanation to your patient. We do know it is a result of death of the dopaminergic neuron in the substantia nigra. The Lewy bodies, which are those inclusions that accumulate in the cells from that abnormal protein misfolding that happens. One of the widely accepted theories of Parkinson's disease is the Brock hypothesis. If you're interested in knowing in detail, you can look at that paper that was published, but he looked at Parkinson's patients across the spectrum at autopsy, and was able to provide a staging system that may reflect the way that this disease progresses. We do know that there is a prodromal syndrome 10 to 20 years before they ever develop motor symptoms. This constitutes usually lack of sense of smell and REM sleep behavior disorder. This disease progresses, and when they usually show up in our clinic, it's around stage 3 or 4, and that's the point at which they have the motor symptoms. We also know, and if you've seen Parkinson's patients, that they typically progress in a fairly stereotypic fashion, and you can usually determine how fast that patient's going to progress and what that looks like. And the disease continues on to involve the cortical hemispheres, and this is reflective in the cognitive impairment and a lot of times the psychosis that they will have at the advanced stage. So most of the time, these patients are going to come for tremor, rule out Parkinson's disease, evaluate their gait. And what we're looking at and what we're looking for in that clinic are the motor features. And here are those motor features defined. I'm not going to read those out to you. Many of you are very familiar with what these terms are. I explained to a patient, contrary to popular belief, you don't have to have a tremor to have Parkinson's disease. What you have to have is bradykinesia or slowness. And an evaluation of that both subjectively and objectively in that initial evaluation can be helpful. But as an evaluating neurologist, it's also really important to know that it is much more than just those motor features, and having a good understanding of the non-motor features can be helpful, especially in that initial visit. When you're taking history and you're looking at all of the possibilities of what this disease can be. And so familiarizing yourself with this can be helpful. Some of the questions that I like to answer at that first visit that can kind of fill in the history, when you see somebody there with a unilateral tremor or just the idea that they've slowed down or they have problems or changes in their gait, some of these can sort of trigger a lot of those non-motor features and some of the evidence that you want to bring out in that history taking. It's also going to help you, and as we move into the treatment options, really understand that patient, really understand the characteristics about them, comorbidities, things that they have a tendency toward, and it's also going to guide your treatment going forward. So I don't want to harp on too long a diagnosis. Many of you are skilled at diagnosing Parkinson's disease. The Movement Disorder Society created a task force and offered up some fairly comprehensive diagnostic criteria in 2015. And that's available, and I do have that content here. But it does allow for the ability to look at that patient, and as you're treating them, and as the treatment gets frustrating because you're not achieving what you hope, it can be important to return back to your diagnostic criteria and just make sure that you do have the right diagnosis. So the MDS first states that you should identify Parkinsonism. So that's the bradykinesia plus or minus the rigidity or tremor. And that's the first step. Identify Parkinsonism and then determine if, in fact, it is Parkinson's disease. Understanding that full diagnostic certainty is impossible. And for me and my a discussion with the patient, I say that very first. I cannot tell you with 100% certainty that this is Parkinson's disease, and I think that's helpful for them to know that this is a working diagnosis. And 75 to 95% are confirmed at autopsy, but what that also says is up to 25% could have a wrong diagnosis or a misdiagnosis. This does reflect many of our disease states in neurology, many of the things that we deal with that are lacking biomarkers, but there is some margin of error that you yourself and your patients have to extend a little bit of grace when you're establishing this diagnosis. But clinical expert opinion does remain the gold standard. I just tell them that could take a little bit of time. It might not be on that first visit. So again, the symptoms that the patients will have, again, just defined here, knowing that postural instability is actually not a part of the initial diagnostic criteria. And if that's an early presenting sign, recurrent falls, you're probably going to want to consider an alternative diagnosis. So you can weigh your exclusion criteria, supportive criteria, if you are one that likes to have clinically probable versus clinically established. That's up to you. You can look at those criteria and decide which one your patient falls into. You definitely want to review your exclusionary criteria. Of course, any cerebellar findings, impaired gaze, dementia, psychosis, symptoms only in the limbs, or if somebody's on a dopamine blocker, you would not be able to give that diagnosis. You do need to have an observable response to high-dose levodopa, and that dose that we're looking for is at least 600 milligrams a day. Now, what I'm not saying is that is the dose at which you should start them at, and we'll talk about that. I've also learned that my idea of a response to levodopa is often different from the patient's idea of a response to levodopa, and so many times when they come back after being on 300 milligrams of levodopa a day, and the question, are you better? It's like, no, I'm really not. Although at their first appointment, they were using a cane to get down my hallway, and now they came all the way down, got on the scale, were in the room. But because they still have a tremor on their right hand, their idea is no. So it is important to know, I'm really doing a detailed exam on that first visit, documenting that response, and then talking about other findings such as the bradykinesia, the rigidity, their pace of their life, that's also responsive to levodopa. I also had 2 patients in the last 3 months who referred to me who had a diagnosis of Parkinson's disease. However, it was extended at a time where those patients were under the influence of alcohol. They had a substance abuse problem. So they came in bradykinetic, tremulous, had problems with gait. There wasn't, I guess, enough history taken at that time. And so that diagnosis was given, and they'd spent a year and a half under this Parkinson's disease diagnosis. Thankfully, they had been rehabbed from their substance abuse, and we were able to lift that Parkinson's disease diagnosis. So know that this can sort of manifest as lots of different things. Again, a robust response to levodopa. Dyskinesias is actually supportive of Parkinson's disease. So if and when you see dyskinesias, hopefully it's not within the first treatment option that you give. That can help you know that you're probably on the right track. Unilateral rest tremor of a limb is uncommon in really anything else other than Parkinson's disease. So again, if they move too fast or they don't move at all, if they have bulbar dysfunction, respiratory dysfunction, autonomic failure, or recurrent falls, these could be red flags that you might be dealing with something else. The lack of those prodromal symptoms, you want to see them at least some point. It may not be the very first visit, but eventually you want to see these come out. So if you're somebody who likes an algorithm, if you like to see things flow, that's what this is. So you've got somebody who comes in probably not sleeping well, maybe some lightheadedness when they stand up. They may have a family history on exam. You see that slowness, tremor. Their voice volume is slow. Their handwriting has changed. You walk them down the hallway and they're not swinging their arm as well. Some of these supportive features, maybe they have a Dat Scan genetic data, which None of my patients usually have. And you think, okay, this is a patient I think has Parkinson's disease. Then you want to review these exclusionary criteria, make sure they're not there. If they're present, no, then you offer them levodopa. They have a good response. Most likely you're there. This can take probably 2 visits, at least maybe more than that. Say they do have exclusionary criteria, they don't respond to levodopa, then you've got more work ahead. What about the Dat Scan? The Dat Scan, it looks at presynaptic dopamine dysfunction. Basically inject a tracer, radioactive tracer that looks at that dopamine system. If there is bilateral and symmetric uptake, they have a normal or intact dopaminergic system, i.e. not consistent with dopamine deficiency. It is accurate. It was approved in 2011 to differentiate Parkinson's tremor from essential tremor. So for those of you trying to get this approved, if you can put that on your insurance reason for getting it approved, it is more likely. I've also found it very helpful to differentiate Parkinson's disease from drug-induced Parkinsonism. I have several patients who have comorbid psychiatric disease and idiopathic Parkinson's disease, so that can exist, and a Dat Scan can be helpful to guide that treatment. It's not going to differentiate atypical forms of Parkinson's disease. It's also helpful to know that if you apply that criteria for clinically definite Parkinson's disease, the accuracy is equal to that of a Dat Scan. And so I, for instance, have 2 Dat Scans that I have access to in my community, and I can tell you that one is helpful, one is not. I don't have access to the images all of the time because one of the institutions is not within my institution. And so I have to be mindful every time I'm ordering a Dat Scan, what am I going to do with the result? Because I have had Dat Scans that were not consistent with my clinical picture. So just be mindful, have a reason for ordering the Dat Scan and what you're going to do when you explain to that patient, it's normal, so the next step is this, or it's abnormal, so the next step is this. There was a review, interestingly, it was paid for by GE, so keep that in mind. That did say it changed management of 54% of the patients and or diagnosis. So it's also helpful if you get about 6, 9, maybe 12 months down the road, and this is just not looking like you thought, a Dat Scan could be helpful at that time. So we're going to look at treatment. The American Academy of Neurology offered new guidelines actually at the end of December 2021 that looked at their opinion on the initial treatment in early Parkinson's disease. So these are patients who were less than 2 years into their disease. They had a Hoehn-Yahr of less than 2, and it looked at levodopa, dopamine agonists, Mao B Inhibitors, and the COMT medications. And so there are 6 guidelines. Each of them have a little bit of a subgroup. I'm going to run through these, but I think it is helpful as you're trying to approach that patient, what you should do for initial treatment. So first recommendation, no surprise, you should counsel patients on the side effects of all of the drug classes and the intent behind that. For recommendation 1B, in patients with early Parkinson's who seek treatment for motor symptoms, clinicians should recommend levodopa as the initial preferential dopaminergic therapy. Lots of drug classes have come out over the last 15 to 20 years, and maybe some thinking had been that we shouldn't start with levodopa, but these guidelines will give us justification to go back to the gold standard and consider that in early Parkinson's disease. Dopamine agonists can be prescribed. It's recommended in a patient who's less than 60, who may be at a higher risk for developing dyskinesias. It's not recommended in patients older than 70 who have a history of impulse control disorder or pre-existing cognitive impairment. They're already sleepy during the day or hallucinating. So again, it's important to learn all of that in your history because it will guide possibly this initial treatment. Studies have failed to provide evidence of disease modification when choosing a drug class. We do know that levodopa improves motor symptoms. It improves mobility over the DAs. Starting levodopa is more likely to induce dyskinesia than if you were to start for dopamine agonists up to 5 years. However, the prevalence of severe and disabling dyskinesia during this 5-year period is low. DAs are more likely to cause hallucinations and are associated with a high risk of impulse control disorder. Spoiler alert, the guidelines are not friendly to dopamine agonists. So if those of you who really like them, I'm just going to give you a warning. You might get your feelings hurt a little bit. We're not meant to do that. But just going forward, you're going to see a lot of negativity around dopamine agonists. And I would say that's consistent with the field of movement disorders. I think we've shifted back towards levodopa just with a conservative approach, and I'll show you what that looks like. Again, those who have predisposing factors for dyskinesia would be younger, smaller females, and increased disease severity. Those who are at higher risk for impulse control disorder are going to be males, younger, history of mood disorder, presence of apathy, family history, and addiction. I often ask patients, and we'll talk about this, so just if I'm going to start a DA for whatever reason, I ask them, do you have a bend towards spending money? How much alcohol do you drink? Like this, are you bent towards pleasure-seeking behavior? And a lot of times they'll tell you, yeah, I mean, I like Vegas, I like alcohol, and so that might be somebody that you want to be cautious. It's not always that clear cut, because I've seen impulse control disorders emerge out of the most unlikely of candidates. But it is important to talk about this. So when you do choose to prescribe levodopa, the recommendation is immediate release versus controlled release, and immediate release over levodopa carbidopa and tacopone. We do recommend the lowest effective dose, and definitely you should monitor for side effects of levodopa. Typically on that second or third follow-up, when patients have this robust response to levodopa, the conversation should be, I realize you're feeling better, don't increase your medicine. So you do need to have clear conversation that if you start at 1 tablet 3 times a day, they need to stay at that unless there's a reasoning. And I ask them to call or make an appointment to schedule why we would go beyond that levodopa dose, because that is an important factor in really having the best outcomes specifically related to dyskinesia. A conversation related to diet, specifically protein in the diet and how it affects levodopa, can be had early on, although this tends to be a later feature, and we'll talk about that. Again, no studies have been shown to comparing IR to controlled release levodopa. Reasons to favor immediate release, that controlled release levodopa is just not as predictable. They're not going to give them that motor control during the day as they need. A lot of times they may stop that later. Immediate release is less costly. It's probably the cheapest one we have. I always tell them once we move beyond immediate release levodopa, we're going to add some dollar signs. So they're usually for the more affordable option. And tacopone can be helpful for end of dose wearing off. Again, that's not typically an early feature. Can set them up for dyskinesia sooner. Levodopas, they obviously do have side effects, impulse control disorder, hallucinations, daytime, again, not as much as dopamine agonists. So the trials do recommend the lowest effective dose of levodopa. So this is anywhere from 150 to 300 milligrams a day, possibly up to 400 milligrams a day. So the way that I start this in my patient population, half a tablet, 2,500, half a tablet 3 times a day for a week to get them used to it. And then I would go to a full tablet 3 times a day on week 2, sort of titrate into that dose, and then they stop there. I ask them to call me if they have some adverse reaction or some reason they can't take that. Otherwise, I want to see them back at a follow-up, and I want to objectively decide what that response is. Nausea is common. That is something probably at least 20 to 25% of patients will have. That is the reason for starting at the half a tablet 3 times daily, and with food, at least early on. We'll talk about separating away from meals later if we need to, but taking it with food can offset that nausea. So the next one has to do with the DAs. This is where you might get your feelings hurt. There's a lot of side effects with DA. The side effect profile is not clean. If you're a regular prescriber of this, maybe you're comfortable, that's fine, but you should regularly be screening for and talking about impulse control disorders, hallucinations, falling asleep without warning, postural hypertension, hallucinations, even peripheral edema can emerge out of this drug class. You should screen them for it. You should screen them every time they come back, and you should also involve their caregiver in that conversation. And it should just be common conversation. Do you spend too much money? Have you maxed out your credit cards? Do you work too much? Do you get up at night and eat? Are you hypersexual? It doesn't take much to see this happen in real life. A patient maxing out 5 credit cards, coming in just $25,000 on $1 scratch off, $12,000 on eBay, male escort showing up at the house because they've been called by the patient. Like, these are very real and impactful. So please have that conversation. Just normalize that. If it's not comfortable for you, there are some scales that you can use to have that conversation with them. Again, more about knowing your patient, knowing the side effects. When you do prescribe a DA, consider what type you're going to prescribe. There's different formulations. Again, the lowest dose is recommended. There's no data to support ropenetrol versus pramipexole, but the extended release versions and the transdermal preparations are friendlier in terms of side effects. So if you can, if insurance will let you, go ahead and use that. Start at the lowest dose. The lowest dose is here at the bottom, 6 milligrams of ropenetrol, 1.5 of pramipexole, 4 milligrams of Nupro, and stop there. If you need to go up, probably want to choose another drug class. So if and when you have a side effect and you need to stop them, do it slow. They can withdraw from the dopamine agonist. And so you want to write out a titration profile to come off, but don't keep them on it if they have adverse events. It just is not good for their quality of life. I usually tell them if we're going to have to take somebody off, I make sure they don't have anything planned for the next month, like no weddings, no family events, no holidays. And I will say, you are going to hate me as I titrate you off of your 4 milligrams of pramipexole, because they do. All of the adverse events go away. We will deal with the motor symptoms in another way. But there truly can be a withdrawal off of the dopamine agonist. So when you look at levodopa versus Mao B inhibitors, levodopa does provide more motor benefit. If you have a patient who may have maybe just a little bit of decreased handwriting, some bradykinesia of a limb, an Mao B inhibitor might be a good start in that patient population. We do know that levodopa does provide better motor benefit. There hasn't been strong evidence in the clinical trials to suggest that Mao B inhibitors provide an excess of benefit. Most of the time, you're going to be adding on additional medications. If you start them on Mao B inhibitors, they are generally well tolerated in general. There's no trials comparing selegiline or rasagiline. We do know that either of those are better than placebo. So if you want to start them, they can be helpful, but you also need to be ready for your pharmacy to call you for the SSRI interaction, which is very old data. The risk is very low. However, they are still telling patients that there's a contraindication with their Mao B inhibitor and their SSRI. I've seen one in practice. It was a patient who was switched from venlafaxine to Luvox, and she was on rasagiline. She didn't end up going to the emergency room for serotonin syndrome. Everything was identified and stopped, and she's perfectly fine. So this is rare and low. It can happen. And I go ahead and tell the patient, hey, if the pharmacy tells you anything about your Celexa, we know about it. Don't worry about it. So what does it look like? This is what the immediate release levodopa, 25-100 3 times a day. If you choose controlled release, also 25-100 3 times a day. There's an extended release carbidopa levodopa. That dosing is a bit different. This also goes under the brand name Rytari. Your Mao B inhibitor, selegiline, rasagiline. Using sulfonamide as initial therapy would be off-label. I have done it. It actually is a good medication to use, but harder to get approved. If you want to make the guidelines mad and you're going to go ahead and start with a dopamine agonist, this would be the recommended dosing that you should start with. Preferably an extended release or a transdermal form. If, for whatever reason, you want to use a non-dopaminergic therapy in general, amantadine, you can start with that. Some people find it helpful for tremor. Typically, it's going to be more for dyskinesias. This is 100 milligrams twice a day. I would recommend taking that second dose at noon or before 2. Amantadine is very stimulating. It can add to insomnia if it's taken later in the day. I personally don't use the anticholinergics class any longer. The side effect profile is just not favorable. So again, for those of you who like the flow chart, the initial therapy, levodopa, dopamine agonists, Mao B inhibitors. Again, the guidelines would suggest that you choose the right, your left side. And then the time comes when you need subsequent medical therapy. And what do you do? So all of these are options for adjunctive to your initial medical therapy. And we'll review these in a little more detail going forward, but you can live actually quite a few years in this second box. You can create the recipe that's right for the patient based on your patient profile. All of these can be used together in sort of a rational polypharmacy approach. But getting familiar with these and how you like to use them is very reasonable. At some point, your patients are going to advance, and then consideration of advanced therapy, as I like to call my clinic next level treatment, which often involves a procedure of some sort. So motor fluctuations, this is where the frustration comes, right? This is where we start pulling our hair out because we kind of know what to do up until now. But it is important that you've done everything that we've just talked about. You've diagnosed it correctly. You've started initial medical therapy in order to move through the motor fluctuations with as much success as possible, and hopefully less phone calls to your office and less frustration on your part. So they're inevitable. They're going to happen. The medicines are going to stop working. Parkinson's inherently is progressive by nature. So wearing off, dyskinesias, 40 to 50% by 4 to 5 years. The feeling is the dyskinesias and the motor fluctuations. It doesn't matter how long the patient's been on levodopa. It's how long they've had Parkinson's disease and how high that levodopa dose has been. Even at that, the severity is not that high. It is frustrating, it is annoying, and it does often prompt medication changes. There's sort of an argument against the watch and wait idea with levodopa, and patients will come in and say, well, I don't want to start dopamine too soon because I might get used to it or it'll wear off. We don't feel that it's a medication tolerance. It's not a loss of efficacy. It actually is inherent and reflective of the disease progressing, losing that long duration response. And that short duration response also decreases, and the brain loses the ability to store extra dopamine. I also tell them an untreated or an undertreated patient reports a much less quality of life than a well-treated patient. So as long as you have a conservative and a reasonable approach to the medication, it can be done. So how do you know? Is it time to change medication? Are they just having a bad week? Is this just a whiny patient? Or is it actually time for us to improve our medical treatment? These are a lot of the questions. If I just can't get much out of them, I'm trying to decide how we're going to move along. Really, the first thing I say, do you accomplish everything you want during your day in general? Are you able to fulfill your day? And if the answer is no, I really can't. I'm just limited. I'm like, well, what is it that you want to do? Well, I want to play golf, or I want to go to the gym, or, I just want to get up and go to coffee with my friends. And then really asking what's keeping them from doing that. I just don't feel like it. My legs are heavy. I didn't sleep well at night. This can sort of give you an idea. Okay, their dopamine levels are low. We probably need to make some changes. If you don't think you're at that point yet, really just restructuring and reframing their levodopa can be helpful. So the first thing I make sure is, one, that they're on a medication schedule. So if they're just kind of taking medication, as they like to say, when I think I need it, which is just like drives me crazy. The first thing I say is, okay, let's set a schedule. What time do you wake up? And what time do you go to bed? And fit those 3 doses down into their awake day, and just start with the schedule. And then once you establish a schedule, we'll look at the timing of your day and we'll decide when you're wearing off and how we need to make that adjustment. If you want to stick with levodopa, and this is kind of where the clinical pearl comes in, if you want to stay conservative on that, one of the things that I found, my first step is just to go to 1.5 tablets 3 times daily. It's a fairly conservative increase. You're obviously adding 1.5 tablets over the course of the day. I also ask them at this point to start taking it away from meals. So an hour before each meal. Oftentimes that looks like 7 a, 11 a, and 4 to 5 p.m. So really shifting it into their awake day. But if your last dose is at 4 p.m. and you're going all the way to 7 a.m., that's a long time. And so if there's any trouble with early morning or nighttime, I've found that dropping in an extended release at bedtime can help cover that 24 hours. It can do it at a fairly cheap cost. And then possibly considering adding on an adjunctive class based on what your patients are actually complaining of. So I'm going to spend a few minutes, because this is where the addition of the drug classes can come into play. So say you want to add another drug class. What does that look like? Well, you consider changing the dose of levodopa, and that would be going probably from immediate release to an extended release like Rytary. So this is very helpful in patients who have levodopa-induced nausea with immediate release levodopa. A transition to Rytary I have found to be quite successful, and we're getting it approved based on that as well. So if they can't tolerate 25/100 3 times a day, 95 of Rytary 3 times a day can be helpful. The conversion from immediate release levodopa to extended release is not smooth. If you haven't seen the app, they have an app. It's nice. You can plug it in and it tells you what to do. But I also tell patients you need to give it a month so we can figure out how to get you transitioned. But this can smooth out motor fluctuations and dyskinesias. If you want to add an Mao B inhibitor, I tend to lean towards rasagiline and or sulfonamide. I don't typically prescribe selegiline any longer. The side effect profile is kind of dirty. Rasagiline is good. It offers 24 hours of relief. Now, this is going to take about 6 to 8 weeks. So this is where you need to document the complaints. You need to tell them stay on it, and I'll talk to you in 3 months about that benefit that they're going to receive. I call this a kind of a behind-the-scenes medication for my patients, and it is smooth and it can help. Adding this often helps kind of level out the fluctuations as well. Sulfonamide or Xadago is also helpful. If you have a patient who has chronic pain, so low back pain, joint pain, sulfonamide, there is data to suggest that it does help in those pain syndromes. It does modulate glutamate through sodium channel blockade, and so there is a basis for that. Patients do well on sulfonamide in addition to levodopa. The dopamine agonists, you can tie those in. If you have a patient with restless leg and Parkinson's disease, I tend to lean more towards the rotigotine patch. If I have to choose a pill, I'll go with Ropenolol ER. I tend to stay away from pramipexole altogether. But that can be a nice addition in that patient. Istradefylline, also under the name Noriance. This can be helpful. It's indicated for wearing off. It can reduce off time by about 1 to 1.5 hours. It's a adenosine receptor A2 antagonist. Basically reduces the hyperactivity of the striatal pathway. It's kind of a novel mechanism of action. This is new to the space. It's not a Me Too drug. Patients who may be apathetic, have a little bit of cognitive impairment, this might be a nice addition for that patient profile. COMT inhibitors, if they have end of dose wearing off, this can be helpful. In all honesty, I tend to not use these too much. It often pushes them to that dyskinetic state. Definitely want to question any dyskinesias if you're going to consider adding this, because you can push them over the limit to that. And this is also the first one I would remove if you have a dyskinetic patient. So you can drop that COMT inhibitor. Extended release amantadine has come on and is very helpful for dyskinesias. Specifically, the Gocovri version does have an additional indication for wearing off. I can tell you this medication is potent. You dose it at night. I don't recommend following the pharmacy's auto titration schedule that they put out. I start the lowest dose and I stay there. It tends to work. When I would move through the auto titration that's recommended, the side effect profile got too high. But this is a very good medication for dyskinesias and wearing off. Probably one of the more popular options in clinic is the on-demand treatment. I think maybe it's because psychologically patients don't actually think they're increasing their medications. And a lot of times they're afraid that I'm going to tell them you need more. So these are in patients who have wearing off. Maybe it's not predictable. Or it's at a certain time of the day in the morning. They're very resistant to increasing medications because they think it's a sign that they're getting worse. And so using on-demand treatment has been very helpful and can actually, buy you some months or years if you're considering going to that next level treatment. Inhaled levodopa under the brand name Ambrosia, injected apomorphine or Apokyn, and sublingual apomorphine or Kinmobi. Advanced therapies for motor systems is that next level. I know there's many general neurologists who are very comfortable walking patients through this, and that's great. If this is a time where you want to refer to movement disorders, also great. Both are right. I think what is helpful though is that you understand, you educate what you're sending your patient for, and so they know and can decide if they're a candidate for that. So these are patients who have medication responsive symptoms. These treatments are not for people who don't respond to levodopa. They need to have responded. The expectation would be to offer their best on state. We can't get better than that unless it's a refractory tremor or they have GI issues. There may be an opportunity to even improve on their best on state. Setting expectations in this part of the disease is very important. Working someone up for brain surgery, whether they would say it or not, they kind of have an expectation that they're going to wake up without Parkinson's disease because it is a big deal. And so being very clear on the expectations from deep brain stimulation and or the medication pump can be helpful. So Any of my patients who's interested in deep brain stimulation, the first thing they have to do is go through full neuropsychological testing, because I want to make sure that they don't have cognitive impairment or untreated psychiatric disease, both of which can and usually do worsen after deep brain stimulation. So consider that as part of your practice. Definitely need to find a surgeon that you can rely on to implant in the correct spot. And then there is regular and routine programming that's required. Patients can have significant improvement in both their on and off medication states with deep brain stimulation. One of the things that you should counsel the patient, though, when they've moved beyond levodopa responsive symptoms such as dysphagia and freezing of gait, their risk-benefit ratio of going for deep brain stimulation may lean more towards the risk, because we would not expect the stimulators to help with those non-levodopa responsive symptoms that can start emerging in advanced Parkinson's disease. So that's an important question to have with the patient. The Levodopa Carbidopa Gel, also known as the Duopa pump. This is, and some would say, a less invasive option for advanced treatment of Parkinson's disease. This does involve implantation of a system, typically by a gastroenterologist, tubing connected to an external pump that the patient wears. It delivers levodopa for 16 hours continuously, really flattening out those motor fluctuations that they have. So moving into non-motor symptoms, we actually do a pretty good job of treating motor symptoms, we in neurology. There's a lot of things we can offer. Patients complain about non-motor symptoms. Data would say this does impact quality of life, maybe even more than motor symptoms. It's not my favorite thing to talk about, but it's what the patients want to talk about. And so it's helpful to have options for them. There's a nice reference published in 2019 by Movement Disorder Society. If you don't have this, you might want to get it printed out, put it in your office if you find yourself struggling to talk about options for non-motor symptoms. They've got lots of charts, lots of tables. They reviewed most of the top. I'm going to review them here briefly, but just so you know, this is a good reference on where the data came from. So moving through the top, depression is a big one. Most of the patients are depressed, or at least benefit from SSRIs, SNRIs. If you're looking for options, these are the ones: venlafaxine, clinically useful, and the citalopram, sertraline, paroxetine, fluoxetine, possibly useful in this patient population. If they have neuropathic pain, insomnia, headache, you might want to reach into the tricyclic antidepressants. And pramipexole actually is a fairly potent antidepressant. So if you have a refractory tremor and a very depressed patient, you might want to use this medication. But it's also important to know, if you're bringing them off of pramipexole, what I've seen and didn't expect is a pretty profound depression to emerge, because it was being treated by pramipexole. So also look for that. If you're going to stop pramipexole in a patient, you may need to have that conversation early. Apathy is an interesting one. This is actually fairly prevalent, up to 40%. Typically, the caregiver is going to complain about this, right? Because the patient's usually not going to come in and say, I'm apathetic, but we can tease it out. Usually the wife says, he's depressed, put him on medication. I'm like, whoa, what's going on? What do you think? He's like, I'm not depressed. I just don't want to go with her anymore. And so then kind of looking into that, this is a very impactful symptom into quality of life for these patients. It's identified likely as a separate clinical syndrome. Treatment can improve quality of life. There's some data to say maybe rivastigmine is possibly useful. I've even gone as far as just having patients schedule their time outside of the house, agree, okay, once a month, will you please go to dinner with her, as an actual treatment to try and offset this apathy. This is a hard one to treat. PD psychosis. This one's also very, very difficult. At least data would say 20 to 50% of patients with Parkinson's disease have PD psychosis. It's very common. Oftentimes it starts as fairly minor. The patient will come in and say, hey, I'm hallucinating all my dead family members every day. Usually it starts, and you have to ask, because they're not going to see it as a problem. Do you ever see things that aren't there? Do you have a sense that maybe someone's in the room that's not? And that's usually it. It's a sense of passage or presence. They're like, yeah, I'm sitting in my chair at night, and I just see the cat run behind the couch. And we don't have a cat. And I know we don't have a cat. So I know it's not there. And so it's not a big deal. I don't see it every day. It's not a problem. It's important to know that PD psychosis can be progressive, just like the motor symptoms. And so document that, talk about that. Hey, there's an opportunity to treat it even at that point. And some would suggest that may be the best time to treat it. Because then what happens is, yeah, I see the cat every day. And since I'm going to see it, I might as well feed it because there's a cat in the house. Like, well, wife gets a little suspicious. I don't know why. Just spits it out. Just ignore it. It's not a big deal. Well, then we're tripping over the cat. And now the cat is attacking the patient regularly. And now it's a problem. Now this happens over, 12 to 18 months out to 2 years. But going back to the initial feeling of passage or presence is probably the better time to recognize PD psychosis and to consider treatment for that, because the likelihood of it going away, unless it's due to that Pramipexole you're prescribing at like 10 milligrams a day, which you should stop, then it's likely going to continue and become a big problem later. Definitely make sure, they don't have chronic UTIs, they don't have a thyroid problem. Also consider non-pharmacological strategies. One of my favorite things that I like is I ask them to buy a laser pointer, and when they see the cat or the guy point it, it's going to disappear because it's not really there. And so if they're not interested in adding an additional medication onto the 4 that you already have them on for their motor symptoms, at least have conversation about it, at least call it out, and know that it's an issue. Visual hallucinations are the most prominent. However, delusions, and for whatever reason, delusions of marital infidelity. Sometimes I think I'm more of a marriage counselor than I am actually a movement disorder specialist, because this is very real. It's very impactful. And what I want to tell them is this is a fast track to facility care, because this really can get out of control and really impact quality of life. And it's hard when their Parkinson's is progressing and you need to increase dopamine, which can then, in fact, worsen the PD psychosis. So this is a treatment dilemma that I'm hopeful we will have more options for. We have a couple. They're not great. This is the options that we have. Clonazepam is useful. I personally don't use it. It's too high maintenance. And I have people driving in from all over and to get a CBC every week or every other week to monitor this is just not realistic. Olanzapine is not useful, so I tend to fluctuate between quetiapine and Pemavantarin for PD psychosis. If I'm going to use quetiapine, usually I'll take the 25 milligram, I'll cut it in half and have them take half a tablet at 5 p.m., because usually you're going to stay in front of that evening sundowning and that evening disorientation and get them transitioned to bed. And then you can kind of work from there if you need to. Pemavantarin or Nuplazid, it's an inverse agonist and an antagonist of the 2A serotonin receptors. It does not have any impact on dopamine. This is a 34 milligram tablet that you dose once a day. Can be helpful. I found it helpful if you'll start when they're just seeing that occasional cat every now and then. And so definitely a field that we need more medications for and more treatment for. Mild cognitive impairment is also interesting. I think it's more prevalent in PD than we actually give credit for. Maybe as high as 42% at the time of diagnosis. It can look different. It's not usually clear cut. Usually in those early stages, we're working on the motor symptoms. We're not really looking at mild cognitive impairment. The domains for which it typically arises: memory, executive function, psychomotor speed, and visual spatial abilities. Where it's actually causing problems is driving. My patients who actually aren't that bad, their caregiver's like, I don't know that they should be driving anymore because they have trouble staying between the yellow and the white. Their reaction time at that intersection gets tough. So these are hard conversations to have when it's a fairly high functioning Parkinson's patient with MCI who may be a driving hazard. So consider having a way to evaluate this and navigating this. Likely that patient is going to convert to Parkinson's disease dementia within 5 years. So here's the definition. They have Parkinson's disease, and then they have MCI, either on formal or screening testing. These are the patients who are probably at risk for PD-MCI. They're older, more of the akinetic rigid phenotype. They're not sleeping well. They're males. They're apathetic. They're depressed. So if you see this patient population, you might screen out for MCI. Treatment's okay. Most of us tend to use rivastigmine, although trials would say there's insufficient evidence to support that, but it does trend towards improvement. And a lot of times we want to feel like we're just doing something for these patients. Rasagiline is being looked at, again, insufficient evidence. Cognitive behavioral therapy, but probably more than anything is physical activity and exercise. And so definitely questioning your patient and putting them into a physical therapy program can be helpful. My least favorite non-motor symptom, and I'm just going to hammer you with this really dense chart, is autonomic dysfunction and Parkinson's disease. So everything on that side is very problematic in this patient population. You can see that there's lots of options that may or may not be helpful in autonomic dysfunction. Orthostatic hypotension, probably because the medications that we give them can help with that. The problem is they're not going to come in and say, hey, I have orthostatic hypotension, right? It might take you a little bit of time to figure out that that's what's going on. They're going to come in and say, I'm not doing well in the mornings, or I'm just falling more. Sometimes I feel dizzy. And so it does take a good history to kind of tease this out. It's important that we tease this out, however, because it would change management. I even have a handout printed in all of my patient rooms, and I'm constantly making copies. It's a front and back on orthostatic hypotension. What are the conservative ways that you can manage that to try and minimize the falling from that? If you're going to treat it, a lot of times before I give somebody medication, the first thing I do actually is look at their med list, and half the time they're on Flomax, right? So because these patients also all need Flomax. So look at that med list closely, or they're on 3 different blood pressure medications. Many times you can make improvements based on that. If they're older and I'm not sure about their cardiovascular status, I will ask them to go see a cardiologist as well. Hopefully the cardiologist will help co-manage this. A lot of times they won't. Many times it bounces back into our clinic because the cardiologist thinks low blood pressure, that's great, better on the heart, but not so much when they're trying to stand up and walk. So these are options to use. Again, droxidopa is great. It's the one indicated in Parkinson's disease, autonomic dysfunction. I also do not adhere to the recommended auto titration on droxidopa that's in their label. I've gotten burned on that as well. So start low, have them call you, and then you can escalate that as you need to. Drooling, glycopyrrolate might be helpful. Botox is great. So if you can do it, it's 2 injections on each side. It's 2 injections down here. They will thank you and love you for life. So if they're coming in holding their own Kleenex box, you probably need to ask them about their drooling. This can be helpful. And it's a lot of times it's a problem at night because they wake themselves up on their own saliva. So that one can be easily remedied. How many times the patient said they're constipated? Every day, right? So much so that I go ahead and have like an auto printout of my recommendations on constipation, so I can just give it to them. So start whatever your recommendation is. There's some options here. That's Amitiza, probiotics. I even start with Colace, Dulcolax, Senna, water, hot liquids, physical activity, and exercise. So just go ahead and have that regimen printed out. Because that constipation in a lot of our patients is just as bad as that refractory tremor or that shuffling gait that they have. Sleep, wakefulness, this one also is exhausting to work through. It's important to know, do they have REM sleep behavior disorder? Do they have sleep apnea? Do they have untreated motor symptoms at night that need help? So running through these questions, looking at their medication, again, if they're sleeping during the day, if they're falling asleep from their DA, or they're just dozing off because they have sleep apnea at night, that can be fairly well remedied. Amantadine, again, either remove it or just get it earlier in the day because it can promote wakefulness. That's going to work against their sleep. I do like melatonin. That's usually my first go-to. I start at 5 milligrams. I'll have them increase to 10. The important thing about melatonin is they need to take it scheduled. They don't just take it sometimes. This needs to be built into their nightly medication. So I will tell them 2 weeks of melatonin, compare that with the 2 weeks prior, and see in general if you're sleeping better. There are some other options there that can be helpful. I also use Clonazepam at very low dose, 0.25 milligrams, 30 minutes before sleep, if they have clear REM sleep behavior disorder. I've found there to be relatively lack of abuse potential or dependency on clonazepam, even in this patient population. It's easy to even stop if they don't like it. Non-pharmacological treatment, this should actually be discussed at the very first visit. Side note, in preparation for my talk, I did an informal poll to my patients, and I told them what I was doing. I said, what would you like for me to tell the audience out there who are managing Parkinson's disease patients? Like, what is it that's been impactful for you? 100% of them either said physical activity, physical therapy, or speech therapy. None of them said that one pill you gave me that changed my life, or that one treatment that we did. All of them said what has been the most life-changing is them adhering to a regular physical therapy program. So I would recommend, if you don't have a favorite physical therapist that you like close to you, maybe you should find one, develop a relationship with one. It does take someone who understands Parkinson's disease, who understands the ongoing need for physical therapy. Those who do sports injuries or joint replacement, they're kind of like a one and done. You don't really need me anymore, which is not true. This is something that I will ask my patients in my HPI when I'm typing what medications they're on. I also type, what are they doing for physical activity? And so we review that at each visit, and we're looking to improve both of those. So find a physical therapist that you like. This is where support groups and things like that can also help. Because it is as important, if not more important, than any medication we can give them to help them maintain their mobility, motor symptoms, and non-motor symptoms. It's also important to set the goal. When I ask them if they're active, and a lot of times they're not, especially if they've been dealing with this for a year or more, I'm not asking you to train for a marathon. I'm asking you to walk around the block 3 times a week, and then we'll build from that. And so just building it in to their regular lifestyle can be very impactful. LSVT big, there's boxing, there's lots of programs that are designed for the gait and balance issues that our Parkinson's patients have. And again, schedule it. I'm like, you're scheduling your medicines. I need you to also schedule that exercise. You cannot under stress the importance of this. And there's a role for this throughout the duration, even in the moderate stage. We're preventing falling. You may transition more to a home health kind of look if they're more sedentary in their home, or start looking at assisted devices. I don't ever call it a cane. I call it a walking stick. And so I have, please go to Cabela's and get your walking stick. It's not go to Walgreens and get your cane, because they are not going to do that. But go get your walking stick, and that can help sort of get them through the times where they need a little bit more stability. Even in the advanced stages, it's helpful for contractures, for possibly any skin breakdown or ulcers that they may have. Again, just making this part of your treatment is very important. Speech therapy as well. It's a lot harder to get them to stay involved in speech therapy. I've yet to have one patient that'll go through a program and then continue on the speech therapy exercises. I'm not sure why. I think they feel silly doing all of those vocal exercises. There's a lot of opportunity now to do this, though, online. A lot of YouTube, things like that. We now have support groups. We have the Loud Crowd popping up to do it in more of a support group fashion. It's important to do this early on when you start noticing the hypophonia, because later on you're going to be worried about dysphagia and more impactful things. So again, making this a regular part of your treatment is important. Palliative care absolutely has a role in Parkinson's disease. I'm fortunate to have a great relationship with the palliative care team. When those goals of care shift from aggressive control of motor symptoms to more non-motor, more quality of life, trying to keep them out of the hospital when they've been to the ER with recurrent falls and they're falling, trying to decide where that fits. This doesn't mean, that I think their life's going to end in 2 weeks. This is more of a palliative care. I think it has to be renewed every 6 months and kind of shift that. It's important, though, that you find someone you have a good relationship with so they understand the importance of the medications. I know this can get a little bit tricky, and if you can find one that still allows them to stay on Gocovri, Rytary, Northera, very expensive medications, or at least choose which ones are helpful, because a lot of times if you remove all of those, which hospice likes to do because they don't want to pay for them, it can really accelerate the course. And also, I expect my palliative care physicians to still allow the patients to come see me. There's a way to get around that billing so the patient doesn't think I'm giving up on them or just transitioning them to go die. This is still a working relationship that we have to treat that advanced stage. Patients are going to ask, hey doc, what's this look like? How long do you think I have? I don't know. I will never answer that. It's important for you to know, however, as you're going forward, data would say 7 to 15 years after diagnosis. I've definitely seen patients live beyond that. But it's important to tell the patient the cause of death is actually similar to all of those who don't have Parkinson's disease. So what this means is you can't ignore your high blood pressure, your diabetes. I still need you to do all of your malignancy screenings. You still need a primary care doctor, because that's going to set you up for the best way to have success through this disease state. I think if there's one thing you should take away, it's setting expectations with your patients, probably for yourself first, but definitely with your patients. And again, this should start at that first visit. I don't have a biomarker. A lot of times I say, well, I just went to that doctor and he had me walk down the hallway and just said I had Parkinson's disease. Yeah, guess what's going to happen here? Like, it's very similar. And just working through and explaining the clinical diagnosis, that we're allowed to change our mind. It takes time to really establish your specific symptoms that you have and the best recipe to treat that. But even going through, especially with tremor, I tell a patient, I will never say elimination of tremor. Elimination is not something that I would ever expect to achieve. Now, if we get lucky, great, I'll take it. But we're looking to reduce tremor. We're looking to improve the use of your hands. We're looking to improve those things you want to do during the day. But also look how much faster you're getting dressed in the morning. Also look how you're able to walk across the parking lot. Those are all things that suggest improvement. And then being very clear about those things that don't respond to levodopa or advanced treatment, falling, freezing, dysphagia. But at the same time, every time I see a patient, there's always something to offer. Sometimes it's a medication, sometimes it's an additional pill, many times it's therapy, sometimes it's just like, hey, you're my best patient for the day. I appreciate you coming here and telling me you're doing well. So don't forget that that's just as much a part of the treatment plan of this population as any other medication that we could offer them. And I think that's it.
Wow, thank you. Just to give you an idea how long I've been around, when I first started practice, Cinnamon wasn't on the market.
Wow.
So this has been like my life history going through this. So I appreciate the all of the pearls, of course, and the history walk. I have a question. As you so well did, of going through each category of medications, and you've been very candid. How about the vendors with DBS? Would you comment on such things as life and effectiveness, please?
Sure. So Medtronic had the DBS space from its onset, 1999, 2000, I believe. Over the last 5 years, there's now 2 new companies, Boston Scientific and Abbott, who have new devices in the game. So I just, in full disclosure, I actually don't have support for Boston where I am. So I don't have use of that. The other 2, I have patients with both. Hard to say, I guess, are you asking like battery life? So Medtronic had the traditional lead. Abbott now has the directional lead, which is a different way of programming, a different way of delivering the current in the brain. And it does appear that there is difference in those leads in terms of side effect and programming. The battery lives themselves, so I have Medtronic on Medtronic, I have Abbott on Medtronic, and I have Abbott on Abbott. batteries. They can be mixed with the leads. It seems like maybe my Abbott batteries are lasting a little bit longer. But I've had a decent enough battery changes from Medtronic to Abbott, and there's been a change in like the clinical response to the programming, and I haven't yet figured that out. So nothing's been shown head to head. My personal decision is based on, one, I have a really good surgeon, and he hits the target no matter what. So I don't have any hesitancy sending for DBS in that right patient. And then I look for the support of the company. I don't really rely much on the brain sense technology of Medtronic. I think that's actually just taking a good history. That seems to, I don't need a battery to tell me if and when the patient turns off during the day. I do like the Apple technology and the Bluetooth interface of Abbott. I kind of dab my toe in the virtual programming. Right now, it's just not working. So through the Apple technology, there is a possibility of programming patients virtually, which could be helpful in some of my patients that live 3 hours away. But we're not there yet. And like I say, not sure with Boston. I hear it's a great product, and I think it is. All in all, to see this device space improving is great for the patients to try and improve the motor symptoms and less of the side effects. So I don't know, I feel like I kind of talked around that question, trying to stay as equal as I can.
I have a two-part question. Is the Dat Scan able to identify stage 1 and stage 2 Parkinson? And secondly, is there any research into disease-modifying therapies for Parkinson's in these early stages?
So great questions. I don't know of any data that would show that the Dat Scan could identify the staging of the Parkinson's patients. I don't know that it's advanced to that point yet. And if somebody has data to suggest otherwise, please let me know. And yes, disease modification early on. There's so much in Parkinson's management and disease state, really looking at that patient who is in that prodromal symptom, really identifying those patients. Because if you take that prodromal stage without knowing anything and you ask them if they're tired, because they're not sleeping at night, they're constipated and they're depressed, because most of them don't know they can't smell, right? So how many people show up at a primary care office tired, constipated, and depressed? And how are we going to grab that population? Starting with olfactory testing, starting with, functional MRI, starting with DAT scanning, and trying to identify in that stage is definitely area of research and advancement. I can't speak to specifics on that and where that is, but yes, and that's been long going. We were even talking about that back when I was a fellow almost 15 years ago, identifying patients at that point.
Katie, thank you, first of all, for a great presentation with wonderful practical tips. You were talking about patients and non-pharmacological therapies, and with all the buzz surrounding the gut microbiome and Parkinson's disease, how do you advise your patients on eating fermented foods, pickles, yogurt? Could you comment on that, please?
Do you realize I practice in West Texas? So I get that question a lot, right? In the land of cattle ranching and dairies. And that's where all of these people who, one, have Parkinson's disease. I stay busy full time seeing farmers and ranchers. But yes, there is a lot of conversation around nutrition and gut microbiome. We do talk a lot about the Mediterranean diet. We talk about, shifting less towards what we eat out in West Texas and more towards that field. But honestly, that's not really a topic that we have specifically related to their treatment. It's more around constipation. I know there's a lot of data in fecal transplant. I think UT Houston was even doing that to repopulate the gut microbiome. So maybe we should invite you up to West Texas and have a conversation with all of these patients who are eating chicken fried steak and whole milk. Thank you. Yeah.
Thank you so much. So I have two quick questions. The gel approach,
Yes.
I know very little about, and
Sure.
I wondered how often that's pursued, when you do it, and cost. And then, just because it's my own interest, when do you pursue genetic testing? Do you do it, and how does that change your approach to patients?
Sure. I'll answer the second question first. So genetic testing in my practice is not found to be helpful. In fact, we were just talking about genetic testing. There is a lot of genetic abnormalities that is associated with and linked to Parkinson's disease. Even in the families that have clear, inheritance, my dad had it, my uncle had it, my brother has it. Even in that patient population, it is not something that I personally pursue because at this point in the management, all of the management would still be the same regardless. And so, at this point, no genetic testing. The carbidopa levodopa intestinal gel, the pump under the trade name Duopa, that is a procedure by which, so this would be a patient who you've tried medications, likely they're wearing off, they likely have dyskinesias. Actually a patient who's having to take levodopa every hour or two because they have to fractionate it so much to try and keep that steady level. That would also be a patient you could consider. And so again, there's nothing revolutionary about the gel. It's levodopa. It's just bypassing the stomach into the small intestine. So it's a PEG-J tube that's actually implanted, connected to a pump that they would wear. Lots of variations on how to wear it. My personal favorite is the chest pack because it's hands-free. A nurse would go out and train the patient on how to use it, but then the patient comes to our office with their materials, and we actually can program the pump. The pump can come pre-programmed based on their dopamine need, but they would come in, we would connect them, turn the pump on, and they typically stay probably 2 or 3 hours in our clinic so we can watch them turn on. They have the option to hit additional dose if they were to wear off during the day. And we actually then have them go to lunch and come back, and we can make sure that their programming is correct. Typically based on their prior levodopa, you can get really accurate with what they need long-term. So the cost, it is covered by insurance, and it actually goes through their Part B Medicare. So if you have a patient paying a lot of money through Part D, the pump can actually be more economical for them because none of it goes through Part D. So you could, in theory, drop anything going through Part D, come through Part B, and get paid for. Takes about 4 weeks to get it approved, and all of that is done on the front end. We've even had a couple of VA patients get approved and get implanted. I've found it to be very beneficial. One of the selling points is it is reversible. I have explanted a patient, so although objectively she was doing really well, it was just kind of awkward in how she was carrying it. She didn't like it, so I told her to turn it off for 2 weeks, go back on oral meds, and she went back to her dyskinetic state, but we pulled the pump, and we were able to do that. So that is kind of one of the selling points to that. But I've seen remarkable response from the pump, taking patients from wheelchair to the gym. They do have to disconnect it if they're going to swim or get wet. And then they disconnect at night, they flush it, go to bed, reconnect in the morning. It's delivered to their house, the cassettes, and they store it in their refrigerator. And they'll just pull it out and let it warm up to room temperature, connect the parts. Okay, thank you.